Welcome everyone to today's webinar, Applied Case Study, Estimating Costs of STD Partner Services in Washington State Health Departments. We are recording today, and the recording for the presentations today will be made available to you via the RAISE and NASTAD websites. Feel free to put any questions you have into the chat or the Q&A. We will have time for questions after the presentations. And today's webinar is a part of a monthly webinar series hosted by RAISE and NASTAD. RAISE is a part of the University of Washington's NIH-funded Research Alliance and Implementation Science to End HIV Hub. And NASTAD is the National Association of State and Territorial AIDS Directors. We support public health departments and ministries in the 50 states as well as the US territories. And our collaboration together focuses on strengthening public health at state and local EHE health departments through implementation science. So some of the things that we do, we focus on webinars on relevant topics. We provide tailored health department consultations, site visits and reverse site visits, as well as hosting and evaluating EHE implementation workshop. Our speakers today are Monisha Sharma, who's an associate professor in the Department of Global Health at the University of Washington. And we also have Rachel Silverman, who's a research scientist in the Center for Biostatistics and Health Data Science at Virginia Tech University. And before I hand it off to our first speaker, just want folks to save the date for our next webinar in January on the 21st, and that will be hosted at the same time. So once again, feel free to put any questions into the Q&A or the chat, and we will get to questions at the end. I'm going to stop sharing, and I will pass it to Rachel Silverman, who is our first presenter.
All right, thank you. Can you all see my slides here?
Yes.
Great. Hi, I'm Rachel Silverman. I'm currently at the Center for Biostatistics and Health Data Science at Virginia Tech in Blacksburg, Virginia. This project, a case study looking at costing and a time study of STD partner services in Washington State, was part of my dissertation at the University of Washington. So I'm going to go through this example, and hopefully it'll give you all a good sense of how we did this project, and hopefully you can apply some of these lessons to your work. So just to put this into context, this project was done in 2016, and looking at the context of STDs and HIV at that time in Washington State, there were increases in both bacterial STIs, gonorrhea, chlamydia, syphilis, and HIV wasn't really increasing, but it is kind of holding steady at this time with new cases. And we can see really distinct gender differences in all of these infections, notably chlamydia, unlike the other STDs shown here, much higher in females. And you also see in syphilis these very different trends among males and females. So you see this really big increase among men and a kind of slight increase among women. Another motivating part of this work was looking at the incidence of HIV following an STD diagnosis. So this was a study done by David Katz previously, and it showed that there was a much higher increased risk of subsequent HIV infection following an STD diagnosis. And with that information, it's really clear, at least among MSM, that an STD diagnosis is a point at which an intervention could be really effective potentially at preventing that HIV infection that could happen, that is more likely to happen after that STD diagnosis. So here's a nice intervention point. So that's, that we're seeing that increased risk after an STD diagnosis, both because of, similar risk behaviors between these things, and also biological mechanisms that having these bacterial STDs can increase the risk of HIV acquisition or infection. So learning about partner services. I think maybe a lot of the audience already understands what this is, but just in case, just to give you a fresh refresher, partner services, also known as contact tracing, is when an index case, somebody who is infected and diagnosed and reported, is contacted by a partner services provider. They're interviewed, make sure that they're linked to treatment, and also understand if their partners are also getting the care that they need to treat those infections since they are exposed. So the objectives of this is to notify, make sure the patient knows that they're infected, that they're linked to treatment, and also that the partners know that they were exposed, are either tested or treated right away to make sure that that infection does not continue to propagate in the population. And the goals of this are to reduce transmission and morbidity caused by untreated infections for these people. And so this is recommended and was recommended by the CDC that all health departments provide the service in order to prevent disease and further transmission. And this was for people with syphilis, gonorrhea, and chlamydia. And I'm focusing specifically on these bacterial STDs and not HIV in this context. So in Washington State at this time, the people who received partner services in Washington State were all people with new HIV infections, everyone with early syphilis diagnosis, men who have sex with men who have gonorrhea and or chlamydia infection, and heterosexuals with gonorrhea and chlamydia infection that had gone untreated. So uniquely in Washington State at this time, most of the partner services interviews were conducted over the telephone whenever possible. Partner services for men who have sex with men, they integrated HIV prevention specifically. So that included HIV testing of all cases and linking them to either treatment if they have HIV or discussing pre-exposure prophylaxis with these people to try to prevent subsequent HIV infection. And partner services for gonorrhea and chlamydia for heterosexual cases included provisions for expedited partner therapy, so providing those partners with treatment without having them go through the step of getting tested themselves, just assuming that they would benefit from treatment directly. And those last two bullets are what were referred to as enhanced partner services at the time, as this was not part of like the standard. So the goals for this project was to assess the costs of STD partner services specifically, so not HIV partner services, but just those bacterial STDs. So those costs being both the money involved and that's spent to provide these services and also the time spent. So this time spent by the personnel at the health department. Where our goals were that these results from the study would inform the operational activities of providing these services, the costs and the budget impact of STD partner services, and to identify potentially modifiable areas that could improve efficiency and better utilize often limited resources that health departments have to dole out. And we hope that this would also inform STD partner service programs at other health jurisdictions and subsequent cost-effectiveness analysis. Excuse me. So we conducted this study at 3 health jurisdictions in Washington State, Seattle-King County, Tacoma-Pierce County, and Spokane Regional Health District. So we have King County in Seattle, the most populated area in the state. We also have Tacoma-Pierce County and Spokane way over here on the east side. And these are places that have a higher disease burden for all 4 of these different infections that we're talking about here, HIV, chlamydia, gonorrhea, and syphilis. These all overlap quite a bit in terms of the disease burden at these locations. They're not perfect overlap, but these do represent highly populated areas where these diseases are spreading. So now I'll go through the costing methods that we used. So we're looking from the perspective of the health department. So we're looking at what resources they are spending to deliver these services. The data collection included a time and motion study where the personnel time and resources were recorded. So anything involving like case contacting, looking people up, any field work that was done, including data entry and any other relevant work that was done to provide these services. We also looked at the financial expenditures focusing on their salaries and any overhead that is spent specifically on the STD partner services programs. And we incorporated the health department surveillance data. So all of these STDs are reportable by law to the health department. So understanding the disease burden was really helpful in understanding how these resources were being spent and why. What was not collected were things related to any of their work that had nothing to do with STD partner services. So some of these people who were providing these services had other parts of their job that were unrelated to this, including HIV partner services in some cases. So this was not included in our data. So to do this work, we first needed to establish relationships with these facilities and groups that we were planning to capture data with. So we contacted and worked closely with the supervisors to understand the workflow, understand the resources that were being spent on these services, what we would need to actually collect the data, and to help us facilitate the data collection itself. We worked with them to develop site-specific data collection tools in collaboration with the supervisors and staff. We wanted the data collection to be as low burden on them as possible. We also worked with the supervisors and directly communicated with the staff to explain our research goals, why we were doing this work, and wanted to make it really clear that we were there to objectively obtain information. We weren't there to judge their performance. So it can be a little bit intimidating having some stranger sit there watching you do your work and recording everything you're doing. So we wanted to make it really clear that it had no direct impact on like the judgment of their performance. It was just to collect information on how they provide these services. I also made a point to bring treats, and that really helped facilitate a good relationship with the people that I was observing. So highly recommend doing something nice for them. Okay, so part of the other data was to establish how many people we needed to observe and interview and like when that would work best. We didn't want to disrupt their normal work as much as possible. So we wanted to understand, how much time each person was spending on STD partner services. This was often laid out in their job description where they would be at, 50% FTE to deliver that service compared to some other part of their job that was irrelevant for this study. So when are they doing this work? When are they working on these relevant activities? When are they doing field work? They might not do it every day, maybe once a week, maybe only one person did that. So to just understand how they did this work and when I could observe the different aspects of the work. So at these 3 locations, King County had the biggest staff because they are serving a much bigger population, so this makes sense. So they had 6 disease information specialists, and Pierce and Spokane both had 5 and 4, and they each had 1 person assigned to data entry and admin. So all of these people are really important in addition to the supervisors. So those are the people that we focused on interviewing and observing. King County had a few other people that were somewhat involved in this work, but I'm not going to focus on them. Their involvement was pretty minimal relative to everybody else's. The supervisor at each of these locations was the primary contact to make sure that we could collect data in the least disruptive way and to make sure everyone was on the same page when that was happening. So first, we needed to understand the workflow. So I've created a flowchart of the case management, so the disease cases that are reported, the case management for those and their partner services work. This facilitates the tool development for data collection and the logistics and helps us to just describe the program itself that we are evaluating. So here's our flowchart. So first the case comes in. It's reported by the lab or healthcare provider by law. A lot of these places separated the work by type of infection. So gonorrhea and chlamydia gets sent one way, syphilis the other way. Gonorrhea and chlamydia, usually an admin staff does the first pass in terms of ensuring the data and helping to assign those cases to the DIS as appropriate. Syphilis, on the other hand, much more urgent. That gets sent to DIS immediately for them to begin working on this. So different paths for these different types of cases. Both of these, once they're assigned to a DIS, the DIS works on assessing the treatment status, the risk level of these people, and to contact them and obtain their partner information. This was split by risk behavior. So men who have sex with men, they're counseled again for HIV prevention, HIV testing, linking them to HIV care if they are already infected with HIV and may have been lost, not linked to care, to make sure they're relinked. Heterosexuals, they're provided expedited partner therapy so that their partners can just get treated right away, assume that they'll benefit from that without needing to test them. And so we're skipping that step to get them tested as quickly as possible. And then the partner is notified by the DIS at the request of the case. Oftentimes the case themselves are comfortable letting their partner know, but if they're not, the DIS can be the ones to do that. And either way, the DIS is the one following up and making sure that partner gets that linkage to care that they need. And yeah, so the treatment is verified for both of those people or multiple people if that's the case. Okay, so the time and motion study for this specific project was broken down into 3 different components. First, we started with interviews. So these were very open-ended interviews to get to know the staff. Observations, so an independent observer, in this case me, would watch them do their work. And then individual case time tracking. So the staff themselves were tracking how much time each case took them and what they were doing for each case for multiple cases. So I'll go through each of those now. So for the interviews and observations, the data collection tools that was recommended to me was to use a notebook. I still have the notebook somehow, but they're cheap. They're really flexible. You can write notes however is best for you, and it's inconspicuous. You know, compared to a big laptop that you might have on your lap, a notebook is much easier to work with. You do have the downside of needing to transfer all of that information into Excel or some other software to be able to actually organize and work with that data. But you can build that based on what you collect. So you could potentially enter this information directly into Excel as you're asking the questions, as you're observing, but you run the risk of maybe your computer crashes. It's a lot more intrusive with a big computer on your lap or needing to use a table that might not be in the room normally. You open yourself to, mistyping something and not realizing that, or deleting something accidentally, and it's just less flexible if you have this structured spreadsheet already that might not capture what you want it to. And you might not know that until you actually start doing the observations. The other option, this was not an option when I was doing this work, but I know that technology has gotten better and there might be digital notebooks that could be used for this type of work that can read your handwriting and maybe make it a lot easier to transfer what you're doing into Excel, not having to type it all out necessarily. So it can function like a notebook, but you still run the risk of the battery dying. It definitely costs more than a little notebook. So different options. So I do think that in most of the situations like this, a notebook is, not very technologically advanced, but it gets the job done pretty well. So the staff interviews for this project were really focused on our goals. So I wanted to understand for each person, which STD, which STI or risk group they focus on. Oftentimes the cases were distributed so that people had a specific focus area. Some people just did MSM, some people just did syphilis, some people did all of them. It just depended on how they structured their work at the different locations. So I asked them how many contacts they made in a day or in a week, because it can really vary a lot from day to day. Different cases might take, a few minutes, others might take hours or weeks to close. How often are they out in the field, if at all? What type of transportation do they use? Are they taking a bus, their own car? Is a car provided for them? And then I wanted to also leave it open for them to let me know about any frustrating parts of their job. So one of the goals of this project is to identify places that could be made more efficient. And the people doing this work often have opinions about that, how their work could be made more efficient, and thoughts about how it could be improved as well. So I wanted to leave it open to them to provide their perspective as well. And oftentimes those things that they mentioned are validated when doing the observations later. So the observations is really just to try to be as undisruptive as possible, to just kind of sit in the corner and watch what they're doing. If I have no idea what they're doing, I might chime in with like, can you explain what you just did there? Are you contacting the partner, contacting the case? But a lot of times I could just tell what they were doing as well. If they're like on hold with a provider, that's also an opportunity where I could maybe ask questions, but tried to keep it as minimally disruptive as possible. So I'm recording the time that they spend doing each individual activity. I usually just look at the clock and record the start and stop time. And then later, once I'm actually entering the data, I'll calculate the actual amount of time they spent doing that thing. So this is in the office with them. And I also join them in field work, and this is at all 3 locations. So I observe all of the relevant staff members that were part of delivering these services regularly. So the admins, the DIS, and their supervisors at all of these locations. And I used 2 half days for each person. So this is 20 people total, to try to capture the variation within and across the staff members and the types of cases. Because again, some cases might take like very minimal amount of time. They're easy to get to. Others might be really hard to reach and hard to find. So different amount of resources spent. Okay, so data management of this information. I entered all of that information into Excel, triangulated it. I didn't want the things that were told to me in the interviews to not kind of make any sense once observed, and that wasn't what we saw. So that's good. I aggregated all that information across the staff members and for this project by the STD focus. So I approximated the time spent and the proportion of time spent on the specific STDs and activities spent delivering these services. So aggregating this information, so on average, we can see the hours per week they spent on each STD and at these different locations, so compare across these locations. So what was really interesting is that King County in this situation spent a lot of time on committing gonorrhea. It's a big population, that makes sense. It kind of confirms what we understand about the disease burden and the number of people that they have to reach. And that kind of made sense with Pierce as well. With Spokane, what was interesting is that they were spending a similar amount of time on syphilis cases, even though King County had 5 times the number of cases. So they were spending a lot more time per case in Spokane for syphilis specifically. And I can get into why that was in a little bit. And we can also look at the granularity, so how they're actually spending their time. So how much time they're spending doing data entry, how much time they're spent actually talking to the case and the partners, how much time they're discussing PrEP for people whom that would benefit, how much time they're spending on hold with the provider because their case report was incomplete. So all of these different things we quantified. This is really hard to look at. So I'm also looking at, presenting it in this way with stack bar charts. So this is just the example of Spokane looking at how they spend their time, how many hours are spent on these different activities. So how much time are they spent faxing, how much time they're doing data entry, all of these different things. And again, you see that syphilis takes up a lot more of their weekly time than these other STDs. Also comparing this across jurisdictions. So this is the proportion of time that they're spending doing these different activities for these different STDs. So we can see how much time they're doing data entry, how much time they're like looking people up on Facebook or other sources of information to try to find these people. How much time they're actually trying to call them versus successfully calling them. How much time they're spending on hold with providers or talking to providers. Usually they might sit on hold for a while, and then it wouldn't take very long once they actually talk to a person to get that information that was lacking from that case report form. And that was time that probably could have been, completely minimized if they just had direct access to the medical records. And I believe that was something that was currently being implemented shortly after I was observing. Okay, so those were the interviews and observations. Now we're going into the case tracking form. So for an individual case, from once they're reported to once that's closed, all of their partners have been contacted, or at least all of the attempts made to do that. So understanding how long that takes and the variation, because again, some cases really fast, some cases really slow. So the three different locations did structure their workflow slightly differently in terms of how cases went from admins to DIS. So we wanted these forms to reflect that, to make the data collection as easy as possible for them. So I worked with the supervisors and the staff with a few different iterations of these data collection tools until it really fit their work best. So between these three different sites, the data collection tools were slightly different to capture that. And so if a case did get handed off to another person, it'd be really easy to just hand this form to that next person. Okay. So we included one single page of instructions. And I reviewed this with the staff before they began the data collection to make sure that they understood what to do and to answer any questions that they had. And this is an example of the form. I know it's kind of hard to see, but the staff collected, from the time the case was report, any data entry that they did, any records that they did, record searches that they did, when they had to contact providers, and then how much time they spent doing these things. So all of this was captured for each individual case. And we did this for multiple cases, and then pulled all of this information from these paper forms into Excel. And again, we tried for this to not be too disruptive for their normal work. So we didn't want them to have to open another window on their computer to enter this information. So ideally, they were doing it kind of as they go. Okay, so the results of that. So this is an example from King County. We had the case information, so we knew what their STD was, what their risk group was, if they were MSM versus heterosexual, or if that was unknown, to understand if there were differences in the time it takes for these different risk groups and different diseases. So we can look kind of at the averages of these. We also did that for Spokane. We did it for all three of those locations, but I'm just showing those two. And one of the really interesting things that came up is that the cases that took the longest in Spokane were those that were associated with methamphetamine use. Those people were incredibly hard to reach. It was really hard for them to find them, let alone interview them and get their partner information. So that was where a lot of resources were being spent, is because of these really hard to reach heterosexual populations that were getting infected with these diseases. The MSM were much easier to reach, much faster to get through. So the time was similar across locations for all of these things, except for those heterosexual syphilis cases in Spokane, which is an issue more in Spokane than other places. Okay, so the other thing that we wanted to evaluate were these enhanced partner services activities. So that's, again, like the HIV prevention and linkage to care when necessary, and the expedited partner therapy for heterosexuals. And that work itself was minimal in terms of the added burden on the staff and resources. Most of the work was done finding these people, doing the data entry, doing the record searches, contacting providers. When they were actually talking to the cases and their partners, that didn't take that much time. So adding a little bit more discussion about these things was very minimal. So adding that really didn't add very much work at all. It was negligible. It was really just like 2 minutes more on average, or 2 to 6 minutes, depending on how much that case wanted to talk. But again, very minimal. Okay, so from this, we can estimate the total time spent per case on average. And again, we see this big spike in Spokane for syphilis. So I did split this up by admins and, DIS, and by STD type. And again, we're seeing that huge spike in syphilis taking up a lot more resources. So again, why is it so different across localities? The disease burden characteristics were driving and are driving the resource needs. So we looked at the surveillance data for some more context on the different disease burden characteristics at these 3 locations. So just to put that into context, I have the wrong year here, but this is 2016. So how much time and effort in one place may not apply to others with different characteristics, but this is what we observed at these 3 locations. So there's a lot more STDs in King County. It's a more highly populated area. This makes sense. A similar number of syphilis cases in Pierce and Spokane, but again, we're seeing a lot more time being spent on those syphilis cases in Spokane because they're much more difficult to reach population. And that's also reflected in the different risk groups. So I also looked at the percent of STD cases by risk group. So this is showing the percent who are MSM. So in King County and in Pierce County, we see, over 80% are MSM syphilis cases compared to 38% in Spokane. So most of the cases in Spokane are heterosexuals, and they're hard to reach heterosexuals versus more MSM who were easier to reach at these other locations. Okay, so looking at the percent of reported cases and how successful they were at interviewing the case, and which is one of the many goals of partner services is to make sure that that case gets contacted. Looking at like the success of that, and definitely a lot of energy was spent in Spokane to make sure those syphilis cases were successfully being interviewed. In Spokane, they were more successful at interviewing their cases than the other places. Definitely all were doing very well, but it does show differences in that. And I will also point out that not all committee cases were assigned to the partner services, and not all of them were successfully interviewed by DIS. Okay. All right, so next I'll talk about the costing. So the costing of financial expenditures, the personnel were the largest cost. So most effort was spent collecting time-related costs. So how much time the staff was spending on these things. So we looked at their salaries, their benefits, and then a percentage of those things were assigned to overhead. So, and this was all information provided by the supervisor. Maybe HR would be another resource to ask for this information, but the supervisors were able to give me this information. These are also government jobs, so their salaries were publicly available as well. But I was just able to get it from the supervisor. So that's 80% of the cost of their salary and benefits, and then you add in a percentage for overhead in this case. So I'm not doing any micro costing in this case. It's really just these high level estimates because, again, it's the workers who are highly trained doing this work, and it costs money to make sure that they can do this work and that they can be hired and retained. So the other information we did collect was information on the vehicles that they had. Again, most of the work was done over the phone, but they did occasionally go into the field, maybe once a week. It depends on the situation. So I did capture information on vehicle use as well. So when they used a company car, how much that costs spread out over like the lifetime of the car, like a decade. The gas needed, and did an estimate for that as well. So other locations might have a completely different resource, expenditures that they'll need to account for, but this is what we did in this case. And then having the amount of time that they were assigned to SD partner services, I incorporated that into our estimates. So this is an example of my spreadsheet where I have the different positions. This used to be people-specific names because people who have been there longer were usually paid more. But I've de-identified it in this case. So I have their salary, the proportion of overhead, their benefits, and then the proportion of that based on their FTE assigned to SD partner services, and their percentage by the different STD itself, either from their assignment or from our interviews and observations. So I was able to extrapolate from the money that was spent on these people and the percent of time they spent for these services to get a number of money spent for these services. Okay. Okay, so looking at what was spent on STD partner services in 2016, makes sense. King County spends the most, bigger population. So it has about twice the expenditures of Pearson Spokane. And then the percent of expenditures spent on each STD, again, looking at Spokane is the big outlier with a high percentage spent on syphilis cases. And this makes sense given the consequences of untreated syphilis in the heterosexual population. Again, it was only 38% were MSM in Spokane of syphilis. So big issue in the heterosexual population in Spokane, given that congenital syphilis is a really serious, terrible thing to happen. We don't want that to happen. We want to make sure every heterosexual case is tested and treated as early as possible, given that pregnancy is also a thing that can happen when you're having unprotected sex and acquiring syphilis. So it does justify that higher associated effort and cost. Also putting it into context with the lifetime cost of HIV treatment is $400,000. That's about what was spent in this year on these programs. So if we can prevent one HIV case, that really shows that these programs are really worth it for that and a whole bunch of other reasons. So from that information, we can then calculate the costs per outcome. So this is the total program cost divided by the number for each outcome in that year. So we're using the actual numbers here. So looking at the different costs. So the fewer outcomes you have, the higher cost per outcome, which makes sense, but so just showing what we can do with this data. So this is just showing the amount assigned for partner services, interviewed, notified, and by the different diseases as well and locations. And yeah, again, Spokane, big spike in that syphilis group. Also looking at that enhanced partner services. So this was officially what we were evaluating for this project. Of course, we did a lot more, but I'm showing those enhanced outcomes as well. So if we can prevent one case of HIV using this, the cost per preventing HIV because we've linked someone to PrEP or something like that. Okay, so just to go through a summary of this particular costing analysis. So we quantified the time and financial costs for delivering partner services. We saw how time is spent and areas where efficiency could be improved. So one of the big things was every single thing that they do had to be entered in their data collection system. And oftentimes a lot of this information was redundant. So that's an area where if they could have a better data collection system, that could really save them time that they could be spending towards actual contacting of cases. Because as we saw, not every case of every STD gets contacted. There are limited resources. So we also could talk about improving access to electronic health records so people aren't spending time on hold with providers, access to a restricted database where you can get address information for cases and partners, and improve data sharing across different health jurisdictions. So one county to have direct access to another county, or for places like Spokane that's like on a state border, having access to that information where people might go across state lines. I also noticed, and they also know this, they often had, at least in Seattle at this time, one person would go out and do all the field work. So anybody's case assignments would have one person go and reach them if they couldn't reach them over the phone or through other methods. So it was one person. And when I was there, this person said, let's use the carpool lane. We drove past an amount of traffic that was amazing. And I was like, this is not a good observation because it's taking us 20 minutes to get somewhere. And she told me just put it down as 2.5 hours. That's how long this ride would have taken if I wasn't in the car with them doing my observations. So obviously having DIS doing this public service they would benefit by having access to that carpool lane to bypass traffic to do their job. The other thing is that this costing analysis showed was that the enhanced partner services objectives required very little extra time and effort compared to the standard conversations that the DIS would have with cases and partners. So this is adding a quick little conversation about these things was very minimal. Okay, another thing to mention is that this helps show that the costs were heavily influenced by the disease burden and epidemic characteristics at these 3 different locations. So heterosexual meth users in Spokane required a lot more efforts to find them and get them to engage to give that interview and that partner information. We were able to calculate the cost per outcome, and this can really help with parameterization for cost effectiveness analyses later. And we can inform program implementation elsewhere. I mean, different places are going to have different issues to think about, but this can really help put some of that into context, like what you'll need, what you should think about when implementing these things. I'll also talk about some alternatives to these resource-intensive independent observations. So not everyone's going to have a grad student who can do these interviews and watch 20 people for half a day and collect these observations, transfer that to Excel, do all of that work to actually get some numbers to work with and present. So some alternatives could be that the staff are tracking their own time. However, this can be disruptive and it diverts their attention away from their normal activities. So it's not a great way of collecting observational information if you're observing yourself. And then you could just do interviews alone. This might be sufficient for what you're doing. It really depends on the program and how nuanced it is. So it might be more efficient to obtain the information. Like just say, how much time do you typically spend doing this or doing data collection or actually talking to people? So asking people to estimate. But people often don't routinely pay attention to what they're doing exactly like this. So you might miss a lot of detail and nuance. And it's more qualitative in that way. Also, having an independent observer and doing this data collection can provide the evidence for decision making and advocacy for researchers to improve efficiency and just the quality of work that's being done. So, if a DIS is saying, I'm spending so much time doing this tedious data entry that could be better, me as an independent observer can say, yes, they're spending this much time doing this work, and yes, it could be made better. So having that validation, I think, is really helpful from an independent observer. Okay, so my final comment on costing analysis. So in this particular scenario, the biggest expense was people. We're not paying for medications. We're not, paying for a new building to be built. And we're not paying for cars very much. So the biggest expense is people. These are people who are highly trained and skilled and effective. So we want to make sure that they're compensated and they have the facilities to work. So that's where we really focused on in terms of monetary costs and also time. So in this case, the infrastructure already existed. So we did not do any microcosting on like equipment, like chairs or desks or computers. But of course, all of those are necessary to actually do this job. We just used a percentage of their salary that was assigned to the overhead estimates. So the resource needs may differ in other settings or doing this kind of work to evaluate different types of programs. So there are definitely other things you might want to think about depending on your situation. Okay, so I just want to acknowledge the people who made this work possible. Dr. Matt Golden was the PI, I believe, in the study back in 2016, as well as the people who worked at these health departments who we observed. This was a CDC-funded project, and if you would like to know more about this work, this is the information for the publication that goes into a lot more detail for this study. But I'll also just share my contact information for anyone who's interested. All right, thank you.
Thank you, Rachel. I see 2 questions, but before we get to the questions, I just want to see if Monisha had anything else to add.
Yeah, we could maybe go through the questions and we can see if there's any time left, and I can kind of talk more about microcosting as an overview and time and motion. But I think Rachel did a pretty comprehensive job, so we'll see maybe after we ask questions if there's time for any more discussion.
Sure, sounds great. Just a reminder to folks, feel free to use the Q&A or the chat to ask any questions you may have. Our first question is, does your study take into account DIS interviews in clinic? King County has a full functioning sexual health clinic, while the other counties you mentioned do not. So just curious if that was part of your observations.
Yeah, so I did observe them doing their normal jobs. So in King County, and I think they did have people come in to Spokane, I believe. I might be getting this wrong because it has been a few years, but yeah, so no matter where they were delivering the services out, that's what I was observing, whether it was in the clinic itself versus just over the phone. So there was some of that where someone would get diagnosed in the clinic and the DIS would go there, and I would follow them in there if the client was comfortable with that. If not, I would just record the time. But yes.
Great, thank you. And then some folks were asking if you could share the link to the study in the chat.
I can.
And I believe those are the only questions I see at this point. Okay, any other questions before Monisha takes over? Okay, I don't see anything in the chat or the Q&A, and I'm not seeing any raised hands, so.
Great, so I'll just maybe chat a little bit with the remaining time that we have. So I think maybe just to complement what Rachel said, she did a really kind of comprehensive job on the time and motion observations of microcosting, and that's really the driver. In many programs, the personnel is taking up the large majority of the cost, so you want to focus most of your time on those either through direct observations or surveys. But just also to talk about some of the other aspects of costing, so you also want to cost the supplies that are being used, the resources, if staff have computers, other things. So that can also, that kind of goes in to the microcosting as well. And as we've kind of discussed, costing in the health department can help support budgeting either for subsequent years of your intervention or for kind of future different programs across the country or the state that might want to implement a similar partner services or whatever health intervention that you're costing. And it can help identify inefficiencies and cost drivers. As Rachel mentioned, you can see quantitatively that even though staff are saying they spend a lot of time on data entry, you can see that 26% of a time working with a case is data entry. So you can quantify just how much resources are going into that, and that can kind of drive advocacy around changing some of the workflows to not only improve outcomes, but save money if staff are not spending time in that way. And so microcosting, as we had kind of discussed in our last seminar, is really kind of an approach where you measure every single kind of supply or piece of equipment that goes into an intervention, and then the quantity that's used, and then multiply the unit cost for each input. So this can be more precise than just taking the whole expenditure budget and then saying this is the cost, because you're really understanding every unit that goes in, and you can kind of look at the cost drivers. How much are you spending on supplies versus equipment versus airtime for staff, and you can get a really detailed description of the finances beyond just kind of like an overall, here's our budget for partner services. But it is a lot more resource intensive. And so that's like kind of the balance that we need to think about, especially when there are limited funds to do this work. And so as I mentioned, the common cost categories are personnel time, which is often the largest cost, but also supplies, test kits, equipment, so the vehicles that Rachel was talking about, and then also the space overhead and administrative costs. And sometimes we can miss those when there's a lot of also management of partner services and quality assurance and review and things that are happening kind of above the staff implementing partner services, and that can take considerable time as well. And so this we kind of mentioned is that we use time and motion to observe how staff are spending their time and then allocate those personnel costs accurately. So figure out how much time they're spending and what their wage rate is for all of those activities. And it's helpful when staff are multitasking and working across programs. So they're funded 100% FTE, but they're spending little amounts on different things. So you really want to understand where their time is going. And it kind of gives you those activity level estimates. So you can say how much time is spent on calling the index partner, how much time is spent tracking, or how much time is spent in the car. And you can really get those kind of detailed breakdowns. And so often, as Rachel showed, you want to define all the activities that are observed. So you take partner services and break it down into the activities that are commonly done. And then you select the staff and observation periods, and then summarize and link to wage rates. And this is just an example of activities. You could have, a client intake, counseling, clinical service, documentation. So that's that data entry, and then follow up. So once you break an intervention down into those little activities, it's more easy to identify how much time and also all the resources that are going in to each of those activities. And as Rachel mentioned, the direct observation is really the gold standard. We really want to, if you really want to truly objectively understand how people are spending their time, watching them is kind of the best way to do that. But it's often a huge amount of time, and Rachel spent a lot of time over many days following different staff and kind of understanding their workflows and recording it and then transcribing it and then analyzing it. So that whole process is a big undertaking. So you kind of want to think about what your goals are and how much you need that level of detail. Otherwise, there could be some self-reported time logs, and you can try to make it minimally invasive. So with time and motion, you can write down every little thing that they're doing, but maybe with a self-reported log, you could just say started partner services, ended, and you can have bigger chunks where they're not writing down, doing something, writing it down, because those kind of minute level activities are going to be very time consuming. And then, of course, surveys, and you can see in, maybe Rachel's or others, how well the surveys triangulate with the direct observation. And if they are kind of matching, then you can have that confidence in surveys working kind of well. And then you kind of do what Rachel did to move from the time to the costs. So you calculate the average minutes per activity you just aggregate everything that you collected and kind of find what is the median time spent on each activity, and then multiply it by the wage rate. And something else to consider is sometimes wages, although in most cases publicly available, can be kind of sensitive information. Sometimes people don't want to talk about how much they're making, especially within a department where people within the same cadre or grade of worker may be making more or less. So that's another area to just be sensitive. You can talk to HR, but you can also use kind of publicly available rates if that's a harder thing to get. And so then you kind of put this all together. So you have all the activities that are needed for the intervention, and then what supplies and what resources are going in to those activities, how much that costs, and then you can sum it over to get client level or total costs. So Rachel presented annual cost of the program and cost per syphilis case reached, cost per partner reached, so you can really understand not only the full bulk of the resources, but for each case, how much are you spending, and for each outcome. So how much money does it take to get someone linked to care? And these are just, examples. You can have personnel. You kind of want to list out who's working on the intervention, there's supplies, and then you can get that output: cost per positive case identified, cost per partner notified. And that gives you kind of a measure of effectiveness, like a cost, sort of like an intermediate cost effectiveness. For this cost, we're getting this outcome, which is someone is notified. And then, of course, the pitfalls are there can always be missing costs. So with microcosting, because you're going through and collecting each cost, it's easy to just miss something if you're not asking about it or if you're not aware of it. You can also double count shared resources. So if partner services is using a piece of equipment, you might count it towards that, but there might be other programs also using it. So it's not fully a cost, like that maybe the car is being used not only by partner services, but by other programs doing field work. And then observation. So if you're observing staff during a particularly busy time, and it, their workflow is different because they're just trying to get a lot done, it might be different than what is typically done throughout the year. So that's also where the surveys come into play, is if people are telling you they spend a different amount of time than what you're observing. It could be because you're observing a busy time, you're observing a slow time. Ideally, of course, you would want these observations to be spread across the year, across the days, because then you can get a better sense of variation. But also, that's hard to do with just the time that you have available, the resources you have available. So those are just some limitations to think about. And that goes into kind of the variation across the days and across the sites. So overall, it helps to just start simple, focus on the main cost drivers, use Excel or paper, something pretty simple to document and produce these estimates. And it's also always helpful to document your assumptions. I'm impressed that Rachel can go back to a 2016 analysis and still remember what she did. I think it's because she documented it really well. You could write things down and then later have no idea what you were trying to say. And these are used in many ways. So you can use them for budgets and for planning, for cost effectiveness analyses, and also to advocate for different funding and policy. So yeah, I think we're kind of at time, but that's overall how we do a microcosting and a time in motion, and then a kind of a case study to illustrate this. So thanks, everyone.